Hello, and welcome to Talk About Tumors with Ryan and Ryan. I'm Ryan Malstead.
And I'm Ryan Quinn.
And today we're going to talk about localized esophageal and gastric cancer.
So this is actually our second time recording this episode. This is the price we pay for living in New York City. We realized after recording the first episode that it was extremely loud outside, and we had trouble hearing ourselves over the background noise.
Somehow, party music and cars multiple floors below was able to outpower our voices.
I guess this is what we get for recording on Cinco de Mayo.
Oh yeah, that's a good point.
Over the next few episodes, we're going to talk about malignancies that are much more difficult to treat than colon cancer. Often these are going to be less chemosensitive and have fewer targetable mutations. However, when localized, there is an opportunity for cure, and this often requires a multidisciplinary management. As far as esophageal and gastric cancer is considered, when they're in the metastatic setting, they're treated relatively similarly, but the treatment varies in the localized setting.
Yeah, so when we talk about epidemiology, risk factors, staging, and presentation, we'll be talking about both gastric and esophageal. However, when we talk about treatment, we'll break off and do them separately. So esophageal is broken up into adenocarcinoma and squamous cell carcinoma. And these are actually very different diseases with different biology. However, they are still treated similarly as of now. Gastric cancer is always adenocarcinoma. In terms of epidemiology, for esophageal squamous cell carcinoma, worldwide is more common, and in the United States was more common up until about after the 1960s, when it started decreasing in incidence, and incidence of adenocarcinoma started increasing. Squamous cell is more common in patients with history of smoking as well as alcohol use. It's thought that maybe the decrease in the United States has been due to decrease in smoking. Adenocarcinoma is common in patients that are obese, which can also often lead to GERD as well as Barrett's esophagus. And it's thought that maybe that's why the incidence is increasing, because obesity is becoming its own epidemic in the United States.
These points are important to keep in mind because clinical trials will vary with time as far as what the populations are considered, as well as by geography. So when we look at older clinical trials, we're going to see a higher representation of squamous cell carcinoma. And in modern trials, we may see some worldwide trials that are going to have populations that don't necessarily represent what may be seen in North America, where adenocarcinoma is predominant.
In terms of gastric adenocarcinoma, there's actually two types. There's an intestinal type and a diffuse type, with different risk factors. So in general, gastric adenocarcinoma is more common in South America, Asia. It's more common in patients with H. pylori. A high yields fact is that the CDH1 mutation is a risk factor for the diffuse type of gastric adenocarcinoma, which it tends to be more difficult to treat. These patients will have a strong family history of gastric cancer as well as lobular breast cancer. And given that it is a significant risk factor for gastric cancer, it's recommended that these patients have a gastrectomy early on prophylactically to prevent the development of gastric cancer. Other risk factors are dietary.
The intestinal subtype is most commonly seen in older patients and is thought to be more likely related to environmental exposures. The clinical presentation of these diseases is relatively similar. Most commonly, what you'll see is a patient will come in with unintentional weight loss, and this may be extreme. Patients will have odynophagia, difficulty often with solid food, such as having meat getting stuck in their throat. They present with pain as well. The extent of weight loss can really be impressive, and people may lose up 30 to 50 pounds in a matter of months. And this is often going to be the most pressing issue when they present to the clinic, as there'll be significant malnutrition. And this is one of the situations where people may benefit from either TPN or PEG feeding in anticipation of curative intent therapy.
One thing that you could see on exam is these patients can have supraclavicular lymphadenopathy. We learn about this a lot as internal medicine residents, that could be a sign of gastric cancer, the typical Virchow's node.
When we get into management, we'll mention that the goals will often be to receive a preoperative either concurrent chemoradiation or chemotherapy. However, these patients may have a severe acute obstruction, and surgery will have to proceed or approach the resection may be necessary to proceed prior to any systemic therapy.
So once we have someone that we suspect either esophageal or gastric cancer, what do we do? What's our workup? So like most gastrointestinal problems, we usually start with an EGD. This will allow us to biopsy the lesion. For cancer staging, we really want an endoscopic ultrasound, which allows us to get the T and N staging. So it allows us to look at the depth of the tumor as well as the surrounding lymph nodes. For patients with upper esophageal or cervical lesions, it's recommended to do a bronchoscopy to rule out a tracheoesophageal fistula. Once you have determined that a patient has localized disease with the EGD and EUS, we really want to make sure that the patient doesn't have any evidence of metastasis prior to considering surgery. We usually next do a PET CT to rule out any other types of distant mets.
So lower esophageal or at the at the end of the EGJ junction or gastric cancers can frequently metastasize to the peritoneum. So in these diseases, part of the workup will also include an exploratory laparoscopy or exploratory laparotomy. And I've seen a number of patients with PET negative disease who, when evaluation of the abdomen is performed, there is extensive peritoneal and omental cancer involvement, and this would be a stage 4 disease. And by doing this, we can potentially avoid the morbidity of a gastrectomy.
I've seen this too in my clinic patients, and it can be pretty devastating for the patients when they think that they've had localized disease. We usually only do the laparoscopy if the patient is found to have greater than a T1B lesion. It may not be needed for patients with more smaller tumors that don't go past the submucosa.
Due to the rise of Barrett's and reflux-related cancer, there's been a rising number of tumors that show up in the gastroesophageal junction. Often it can be very difficult there's no discrete line from where the esophagus ends and where the stomach begins, and often these tumors can overlap and spread among both areas. When a tumor is in this area, it's important that an experienced specialist in this field performs the endoscopy, because they'll have to make a determination of where the epicenter arrives in order to subclassify this as either an upper GEJ or more distal GEJ, which are separated into 3 categories called Seward 1, 2, and 3. Whereas Seward 1 and 2 are treated more commonly like an esophageal, and Seward 3 becomes more and more like a gastric carcinoma.
So now we'll be talking just about esophageal cancer and its management. So as Ryan said, this really is a multidisciplinary disease, and most patients do end up getting presented at tumor board to discuss with the surgeons and endoscopists regarding the management. Patients with T1A lesions, so these are lesions that are confined to the mucosa, can often be treated with just endoscopic resection alone. You want to make sure that you have a very experienced advanced endoscopist doing this. But when you do, we can usually get good results just by resection during the endoscopy. For T1B lesions, which these are lesions that go past the mucosa into the submucosa, it's a little bit controversial in this area. Some places will still do the endoscopic resection. However, some will require esophagectomy in order to treat this.
The best data looking at the advantage of endoscopic resection was a clinical trial that used fairly strict inclusion criteria, which were T1 lesions that were confined to the mucosa, as Ryan had said, were also subclassified as being low risk, which is to say that biopsy showed a well-differentiated tumor that was less than 20 millimeters in length without any ulceration. So for poorly differentiated tumors that are greater than 20 millimeters in length or without ulceration, there is not as strong evidence to support a localized resection and are more likely to warrant a esophagectomy. However, as endoscopic interventions become more advanced and patient and providers become more skilled in these techniques, we have been seeing a shift to more and more attempts of providing the less morbid surgery, as understandably esophagectomy has significant short-term and long-term complications. So although surgery alone for T1 node negative tumors is thought to be curative in greater than 90 to 95% of patients, there's a sharp drop-off and risk of recurrence gets much higher when we move into tumors that involve the mucosa propria. T2 lesions are relatively uncommon to come across, and due to this, there's limited data. They've historically not been included in the multimodality trials that we'll talk about shortly, but they're understood to not fare as well when receiving surgery alone, and it remains a debated area of how to manage these patients when they do arrive.
So getting past T2N0, any lesion that's T2N1 or greater, there is some more data that chemoradiation and surgery all play a role rather than surgery alone. These patients have a pretty poor overall survival and high risk of recurrence if they just have surgery alone, which led to the exploration and development of perioperative chemo and radiation for these patients.
Historical population studies have shown 5-year overall survival of being less than 30%. More recent estimates have shown maybe this being in the range of 30 to 46%. The majority of deaths in these patients are from disease recurrence, and the major impact on overall survival is whether or not the tumor is completely resected. And you'll hear terms called R0, R1, and R2 resections, which is either which R0 being at the margins of our resection, there's no evidence of tumor. R1 being there's microscopic evidence, and R2 there being gross residual tumor at the margins of the resected lesion. There's a steep drop-off in survival with this, so great interest was had to try to improve the rates of R0 resections, which was using therapy prior to surgery to shrink the tumor, make it more likely to achieve a complete resection.
Now, speaking about the lymph nodes, how do you know which is considered regional versus metastatic? So for esophageal cancer, the regional lymph nodes are the celiac nodes, the supraclavicular lymph nodes, and the mediastinal lymph nodes. So any other nodes, the hilar nodes, the distal celiac nodes, any other lymph nodes would really be considered metastatic disease.
The modern standard of care approach to esophageal cancer is utilizing what's known as the CROSS regimen. The CROSS trial was published in 2012 in the New England Journal, and they took patients with resectable T2 or greater or node-positive tumors. 75% were adenocarcinoma, 75% as the esophageal gastric junction, and they were randomized between preoperative concurrent chemotherapy and radiation versus surgery alone. The chemotherapy used in this trial was carboplatin with an AUC of 2 and paclitaxel at 50 milligrams per meter squared given once a week for 5 weeks, during which radiation therapy was given for 5 days a week and weekends off. For the sake of time today, we're going to defer the discussion on details on both carboplatin and paclitaxel because we're going to have lots of opportunities to talk about them in later episodes and discussions. This trial is well represented of the modern patient population in Western Europe and North America, as it had 75% of patients having adenocarcinoma, and 75% of these were in the esophageal gastric junction.
So as expected, the rate of complete resections, so the R0 resections, was higher in the patients that had pre-op chemo RT at 92% versus 65%. And there also was an overall survival benefit seen both at 5 years and 10 years. So 5-year overall survival was 47% in the chemo RT arm versus 33% in the surgery alone arm. And looking at 10 years, the overall survival was 38% in the chemo RT arm versus 25% in the surgery alone arm. Interestingly, the overall survival benefit actually seems more prominent in the squamous cell carcinoma group than in the adenocarcinoma group, which kind of goes along with, as we'll see, we generally think that squamous cell carcinoma is generally more sensitive to radiation than adenocarcinoma.
The median overall survival was 50 months in the concurrent arm versus 24 months with surgery alone.
When they broke this up into adeno versus squamous cell carcinoma, and again, there was 75% adenocarcinoma and only 25% squamous cell carcinoma.
In general, this is a fairly well-tolerated regimen. These patients are often quite malnourished and sometimes frail at the time of treatment initiation. And fortunately, the toxicity here is not as bad as some of the other regimens we'll see, especially when we move into the gastric cancer perioperative regimen. Patients do have localized symptoms such as localized radiation toxicity. There is a risk of myelosuppression, although relatively mild at these doses that are being used. And 90% of the patients were able to complete the treatment course in this trial.
The surgery was done anywhere from 4 to 6 weeks after completing the chemo-RT. This was to allow patients to recover from the chemotherapy and radiation, as well as to allow the maximum benefit of radiation, because the benefits can be seen weeks after the last dose is given.
Now, although the outcomes were improved for the squamous cell carcinoma patients in the CROSS trial, as mentioned, this was the minority of patients represented in this trial, and the historical studies that had more cervical squamous cell carcinoma patients used often a combination of cisplatin and 5-FU as part of their chemoradiation therapy. There's no clear evidence to choose one regimen over the other. I think this leads to some debate over what's the best regimen to use in these patients with the upper esophageal cancer, and I'm not too sure what the right answer would be.
So many of these patients, many of them will not be surgical candidates when you meet them. So then the question is, can you just do chemo-RT and get decent outcomes? And there have been meta-analyses looking at this for patients that do not end up getting surgery and just get neoadjuvant chemo-RT. And if you do have a pathologic complete response, some patients can have a decent overall survival just with the chemo-RT without the surgery.
The best outcomes are still most likely with the combination of chemotherapy, radiation, followed by surgery. However, if someone's not a surgical candidate, you can still use a regimen such as the cross regimen with the goal of cure, understanding that the rates of cure are.
Yeah, this is especially true for patients with adenocarcinoma. For patients with adenocarcinoma, since we think that it's not as sensitive to radiation, you really want to get these patients to surgery if at all possible.
So before moving into the management of gastric cancer, I just want to briefly go back to the esophageal gastric junction. This is not a sudden transition between two sites, and a lot of the clinical trials that our evidence is based upon have intermittently included EGJ tumors as a gastric tumor or EGJ tumors as part of esophageal tumor. Currently, the standard approach are the upper EGJ, such as Seward 1 and 2, to approach them more as a esophageal tumor. And for EGJ tumors that are more than 2, with an epicenter that is more than 2 centimeters deep into the stomach, you're going to be thinking more towards a gastric.
It should be noted that patients with a T4B tumor, that is a tumor that's invading through the wall of the esophagus and into adjacent structures, these are actually, even though they may seem localized, are considered stage 4A, and surgery is not really an option for these patients, unfortunately.
We're looking at gastric adenocarcinoma. Approach for the superficial tumors, as Ryan mentioned, is in some of these either the TIS or T1A, we may be able to get away with endoscopic resection. It's sometimes a little bit more difficult with the stomach because these tumors can spread quite widely superficially and sometimes may not be readily apparent on endoscopy. So it's important that if a local resection is performed, that close endoscopic surveillance is performed afterwards. Once again, our goal is going to be to obtain an R0 resection, and due to this, there's a preference to approach these with systemic therapy prior to resection. Although the optimal approach will be having treatment to be initiated prior to surgical resection, sometimes these patients may present with acute bleeding or frank obstruction, and resection will be done prior to being able to receive systemic therapy. In those cases, there is some evidence to support adjuvant approaches as well, which we'll get to in a moment. But we'll start off by talking about the ideal scenario where a patient is receiving perioperative therapy.
So one of the first studies looking at this that showed a benefit is a British study called the MAGIC study. And this was a study looking at perioperative, so that is 3 cycles of chemotherapy before surgery and 3 cycles after surgery. This study used a regimen called ECF, which is epirubicin, cisplatin, and 5-FU. It included 503 patients, and the majority, 75%, had gastric cancer, and 15% had GE junction adenocarcinoma.
The ECF regimen is adapted from what was the standard of care for metastatic gastric cancer at the time. It's worth mentioning that this is a very toxic chemotherapy complicated by a lot of nausea and vomiting, which isn't necessarily the nicest thing to give to someone who has a tumor already within their stomach and difficulty tolerating PL. This is reflected in the proportion of patients who managed to get therapy after surgery, which was only 40%, with many either too ill to be able to handle it or just outright refusing chemotherapy given how their preoperative experience had been.
So looking at the outcomes, the patients that had the perioperative chemotherapy did have a higher rate of an R0 resection, so 79% versus 70%. More patients were found to be downstaged after chemotherapy, so more patients had T1 and T2 tumors after chemotherapy, 52% versus 37%, and less patients had node involvement. Looking at the overall survival, the 5-year overall survival was 36% in the chemotherapy arm, with 23% in the surgery alone arm.
Just a brief FYI for reading pathologic reports and staging reports. There's different ways of staging tumors, and those of you who've already been spending time in the oncology clinics are well aware of this, but I just figured it's something worth mentioning. And you'll see either C staging, which would be like a CT-CN staging, which is our clinical staging, either based on physical exam or radiographic imaging. You may say P staging, which would be like PT, based on our pathological report. Occasionally, you'll even see a YP staging, and that's what we'll be talking about here with the downstage tumor. So Y staging is the pathologic staging following a neoadjuvant therapy. And this magic regimen had been the standard of care up until just a few years ago, where a randomized trial had compared a novel regimen, which is called FLOT4, which is a combination of oxaliplatin, docetaxel, 5-FU, and leucovorin, given every 2 weeks for a total of 4 cycles prior and 4 cycles after surgical resection. This FLOT4 trial directly compared to the magic regimen and found an even improved overall survival, with 3-year overall survival 57% versus 48%, a higher rate of patients being able to complete postoperative therapy at 50% versus 37%. Both of these regimens are highly toxic, and rates of hospitalizations approach about 50%. The toxicities in FLOT4 are more predominantly neutropenia and neutropenic fever, as well as diarrhea. Today, the FLOT4 would be considered the standard of care, although it does require a patient to have good performance status, keeping in mind that our goal is to improve their outcomes of surgery, and in order to do so, we need to be able to effectively treat someone and still have them in good functional status to undergo a major surgery such as gastrectomy.
One question always is, given the significant toxicity with the FLOT4 regimen or the ECF magic regimen, how should we approach patients who have performance status that may make them poor candidates for these treatments? In my experience, most patients who are candidates for gastrectomy will be able to tolerate either these chemotherapy regimens, although there are interests at using less intensive therapies.
So sometimes FOLFOX is used. This is extrapolated from the use of adjuvant, FOLFOX, or CAPOX. If we think that they can't tolerate FLOT, we'll do 4 cycles of FOLFOX preoperative and 4 cycles postoperative. There hasn't been any, at least as far as I know, of randomized trials looking just at the perioperative FOLFOX.
Yeah, I think it's important to keep in mind fewer drugs will decrease the response rate, so this would not be a preferred choice, but obviously in real life things come in differently than our clinical trial settings, and there may be a patient here or there that you really do want to try to get that response and you really are worried about some potential toxicity using a 4-drug regimen.
So as we had mentioned, sometimes patients do end up having surgery up front without any preoperative chemo. This happens commonly if a patient has uncontrolled bleeding, if somebody has a suspected T1B lesion and has surgery and turns out to be greater than T2 or node involvement. In these situations, what do? They didn't have any preoperative chemotherapy. So there have been studies looking at the role of adjuvant chemotherapy as well as adjuvant chemoradiation for these patients that did not have any preoperative therapy. So one of the important factors that helps us to decide if we're going to give chemotherapy or chemoradiotherapy is the extent of the lymph node dissection that was done at the time of surgery. So there's 2 different types of lymph node dissections. A D1 dissection is basically removing all of the perigastric lymph nodes. A D2 dissection is essentially a D1 dissection, so you remove all of the perigastric lymph nodes, as well as the lymph nodes on the celiac axis, the gastric artery, the splenic hilum, and the splenic artery.
Other things that we look at following initial surgery, or whether or not an adequate lymph node harvest was obtained, not unlike with colon cancer, with a goal of greater than 15 lymph nodes being resected. Primary trial that has shown benefit of adjuvant concurrent chemoradiation was the INT-0116 trial. This used a 5FU-based chemotherapy, course of radiation. In this trial, an overall survival benefit was shown, with a 3-year overall survival with 50% versus 41%, and favoring the group that received concurrent chemoradiation. In this trial, only 10% of patients had a D2 dissection, so this is generally thought to be a trial representative of D1 dissected patients.
So looking at studies that included D2 resections, there are a few studies, the first one being the ARTIST study, which was only patients that had a D2 resection. This study used a similar regimen of chemotherapy versus chemo-RT and showed no added overall survival benefit of the radiation in patients with D2 resection.
And the ARTIST trial was followed up by the ARTIST-2 trial, which looked at patients who had only node-positive disease, so trying to select those who had extensive resections but evidence of localized spread. And this also was unable to show a benefit of concurrent chemoradiation over chemotherapy alone. So currently the standard would be for patients who have a D1 dissection, we do not feel as comfortable that we've fully removed all the metastatic lymph nodes, and adding radiation localized in addition to chemotherapy is thought to provide better outcomes. However, if an adequate lymph node harvest and depth of resection was obtained, we can get by with less toxicity using an adjuvant chemotherapy regimen alone. And this is often used as a 5FU doublet, such as FOLFOX or CAPOX. I have not used CAPOX as much in my experience for this patient population. To me, it seems a little challenging to give someone an oral chemotherapy right after gastrectomy, but it is considered to be the standard approach. And meta-analyses of these adjuvant trials have found an absolute overall survival of 5 years to be around the range of 6.7%.
So thinking about surveillance after you treat these patients with surgery and chemotherapy or radiation, most recurrences occur within the first 5 years, especially in the first 2 years. So we see these patients every 3 to 6 months for the first 2 years, and then every 6 to 12 months for years 3 to 5. In terms of imaging, so the guidelines do differ. We can do imaging every 6 to 12 months for the first 2 years, and then annual CAT scans up to 5 years out. After 5 years, the risk of recurrence is low, so we'll usually stop doing surveillance after that.
The NCCN does mention a role of surveillance endoscopy for some of these patients. However, I think it's important to select the patients that we're doing surveillance endoscopy and thinking about what we would do should we discover local recurrence. I think in those who may be candidates for further resection, or maybe those who did not receive any radiation as part of their perioperative management, there could be some justification for attempting to identify local recurrence as soon as possible, as there may be local management approaches.
And as a last thing before we sign off today, we want to talk about one of the latest and greatest trials in localized upper GI cancers. And this trial is specifically for esophageal and esophageal gastric junction tumors. And this is the Checkmate 577.
So this was a study that was published in the New England Journal of adjuvant nivolumab in patients who had neoadjuvant chemoradiation and had surgery and did not achieve pathologic CR, so did have residual disease on the surgical specimens.
There's been interest in including immune therapy in localized setting for gastroesophageal tumors, and as we move into the metastatic lecture tomorrow, we'll explain why this has been shown to have benefit for patients in that setting.
So in general, about 70% of patients will not achieve pathologic CR after chemo-RT, and these patients have a pretty poor prognosis and have a high risk of recurrence.
This is a blinded randomized trial, so patients following surgery were randomized to either nivolumab or placebo, given for a total of 1 year. They were stratified based upon TPS status, so this is PD-L1 status within the tumor itself, whether or not that was present, greater than 1% or less than 1% of cells. I'll mention that midway through this trial being run, it was found that the TPS score for PD-L1 status was determined to be not necessarily a reliable marker for gastric cancers, and In the results, they'll be speaking a lot about the CPS score, which is the complete positive score, looking at both tumor cells and the surrounding lymphocytes for PD-L1 status. Unfortunately, that means that the CPS will not be a stratified factor. It will be often used more and more for trials moving forward and is probably a better reliable marker of response in these cancers. They're also stratified by histology, whether they're squamous or adenocarcinoma.
The primary endpoint of the study originally was two co-primary endpoints, so disease-free survival and overall survival. However, they did end up amending this and just having disease-free survival be the primary endpoint, with overall survival becoming a secondary endpoint during the study.
So this will be a common thing we're going to see in a lot of the newer trials that are coming out with DFS being used. On prior episodes we've discussed there is a standardized method of identifying whether or not endpoint is a surrogate endpoint. In the adjuvant space for gastric trials, there have been some meta-analyses using individualized patient data that have shown that DFS is a reliable surrogate for overall survival. This has not been shown as specifically in the esophageal space, but there is some thought that it probably can hold up for these cancers as well.
So getting into the results, the median follow-up time was around 2 years, and there was an improvement in disease-free survival in the entire trial population. The nivolumab group had a 22.4-month disease-free survival, and the placebo group had an 11-month disease-free survival.
When looking at the population, the patients who are ultimately ended up in this trial, this was a worldwide trial, so there was a higher rate of squamous cell carcinomas than that would be usually seen in the United States or Canada, and 30% of the patients had squamous cell carcinoma. 60% of the tumors originated in the esophagus. The remainder would be at the EGJ junction. This DFS was shown to be more significant in patients with a CPS PD-L1 score of greater than 5%, with a hazard ratio of 0.62 in this group, and were unable to show statistical significance in those with a CPS less than 5% at 0.89. However, keep in mind that this was not a stratified patient population.
So breaking it down by adenocarcinoma versus squamous cell carcinoma, squamous cell had a greater benefit with the immunotherapy, with a disease-free survival of 30 months versus 11 months. With the adenocarcinoma patients, the disease-free survival was 19 months versus 11 months. So you can see the squamous cell, it looks like in the study, had a greater benefit with the adjuvant nivolumab.
So based upon these results, for patients with residual disease after concurrent chemoradiation followed by surgery in an esophageal or junctional tumor, most providers would consider adjuvant nivolumab for 1 year. I think there's good reason to do that based on the data we're seeing here. Certainly we look forward to some survival data.
The utilization of immune therapy in upper GI malignancies is relatively a new and emerging area. I wouldn't be surprised if we'll see over the next couple of years publications looking at incorporating immune therapy into the neoadjuvant space, as well as possibly a perioperative approach. And we'll certainly anticipate seeing things that change as more and more publications emerge.
Okay, so I know that was a lot of numbers and a lot of trials thrown at you. So we just want to give some take-home points for localized gastric and esophageal cancer. So looking at esophageal cancer, the standard of care is a cross regimen, so chemotherapy and radiation preoperatively, followed by surgery, which can improve overall survival in these patients and decrease the risk of recurrence.
In the gastric setting, we're going to be looking more at a perioperative chemo alone management, which right now the best treatments that we know of would be using the FLOT regimen, 5-FU, oxaliplatin, and docetaxel with leucovorin, given for 4 cycles prior and 4 cycles after surgery. An active area of interest and debate is how to manage patients with an EGJ juncture, and this is becoming more relevant as it's emerging as the most common site for these tumors to arise.
In patients that have already had a surgery before you get the chance to see them, there is evidence to support chemoradiation in patients that have had only a D1 dissection, so kind of a lesser lymph node dissection. If patients have had a full D2 dissection, then you can do adjuvant chemotherapy alone without radiation.
Finally, in For esophageal tumors, that there is some residual disease at the time of resection, there's evidence now to support utilizing adjuvant immune therapy.
And as always, we always want to make this a multidisciplinary approach, so it's extremely important to get your radiation oncology colleagues, surgical colleagues, advanced endoscopists, everybody's input. These are really patients that you want to be presenting at tumor board when you first get them to, speak about staging and candidacy for surgery.
And although the outcomes can sound dire when, in general, with our best standard of care approaches these days, having 5-year overall survivals around approximately 50%, I think it's important to keep in mind, not long ago with surgery alone, we were looking at 5-year survival around 30%. So we have made improvements in this disease. However, we have much room to go before our job is done trying to tackle these very challenging malignancies.
So on that uplifting note, our next episode is going to be talking about these diseases in the metastatic setting, so metastatic gastric and esophageal cancer.
Thanks again for listening. Please send us any feedback through our email or Twitter, and we hope to see you next time.
Take care. For more information, follow us on Twitter at Talking Tumors, or feel free to email us at talkingabouttumors@gmail.com.
Please rate and review the podcast. We really appreciate it.
And special shout out to our friend John Kim for all of his musical talents.
And he is the composer of the music that you're hearing right now. Talking About Tumors is not medical advice.
For medical advice, please contact your own healthcare provider.
Opinions stated on this podcast are by the Ryan who said it and no one else. We have no financial disclosures, and this is done purely on our own time to the sake of our enjoyment of the field of medical oncology. Thank you for listening, and see you next time.